Want to go? Feel free.
Okay. Thank you everybody for joining us today, and thank you for taking the time to come to PQMD's June Pillar Talk, the effect of vaccine nationalism on refugees, internally displaced persons, and migrants, a part of a larger series of webinars which the PQMD community of practice offers to address major trends, leading thinking, best practices, and provocative issues in global health. PQMD is able to put these webinars together because of the strength of our coalition and the depth of the work our members do every day. I'm Elizabeth Ashbourne, PQMD's Executive Director, and I want to welcome you on behalf of our entire team. For those of you who are not familiar with PQMD, we are a global alliance of international NGOs and leading healthcare companies committed to advancing the role of product donations worldwide. Founded in 1999, our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster response, preparedness, guidelines, and knowledge management. Today, the work of our members is central to the global response to universal health care, as well as the international response to the coronavirus. Our members are focused on critical supplies, supporting healthcare workers, donating cash where most needed, and of course, strengthening health systems to promote sustainable access to quality healthcare in underserved communities and populations in crisis. So very quickly, I wanted to review some housekeeping rules. Go ahead and warm up your fingers. Please type your name in the chat box and let us know your organization as well. Because of the large audience, we are actually going to mute everyone and also disable your videos. So if you need anything, please make sure to put it into the chat. We do invite you to use the chat box for questions and comments throughout the entire discussion. And this session is being recorded, so you'll be able to go back and listen to it again or share it with others. And I will share the link for the PQMD's online community of practice in the chat box. So please be sure to join the timely and informative discussions with our members there as well. So now I have the pleasure of turning it over to Dr. Kate Telenko, who is moderating this session. Kate is a globally recognized expert in health workforce, digital health, e-health, global health security, and health systems strengthening. She currently serves as the founder and CEO of Corvus Health, a global health workforce firm. She has received a Rayner Arnold Fellowship for Innovation and Global Development, is listed in Women in Global Health's list of 50 women experts in global health security, and was named one of 300 women leaders in global health by the Geneva Graduate Institute of Development Studies. And I personally can also say that I think Kate is absolutely awesome. So I've known her for a really long time, and I'm really excited that she is able to join us. Kate also provides on-air commentary on COVID-19 for Fox Business News and the Chinese Global Television Network. And I would like to mention that Kate is also a guest lecturer in the PQMD Development Essentials course offered throughout the year, and the next cohort will be starting in September. So if you don't know about it, please have a look on the community of practice or on our website, and we'd be happy to send you information. Kate's extensive work in health systems, and livelihood gives her a truly global perspective on crises around the world, making her an ideal moderator for today. So thank you very much. And Kate, take it away.
Thank you so much, EJ. I really appreciate it. And thank you for the audience for being here and for joining us on this webinar for a discussion on vaccine nationalism, COVID and displaced people. Vaccine nationalism is a new term. It's one that was coined very recently. And it's very important in the context of displaced people. There are now more displaced people in the world than any time since World War II. And I want to start with a couple of definitions for clarification. So since vaccine nationalism is a new term, want to define it. So we're referring to the practice of countries vaccinating low-risk people in their country before other countries are able to vaccinate high-risk people within their borders. So risk can be defined by occupation, such as health workers or essential workers, or by circumstances such as overcrowding and lack of access to healthcare experienced by displaced people, or COVID risk can be defined by biological conditions such as age or medical condition. Internally displaced people are people who have been displaced from their homes and communities, but are still in their home country. Refugees are people who have been displaced from their home country and are currently living in a second country, whether documented or undocumented, in camps, or in the community. Migrants are people who willingly move to another country either for economic opportunity or family reunification. And migrants can be documented or undocumented, and they can be in facilities such as at the US border, or they can be in the community. And given the complex nature of this topic, PQMD has decided not to do the traditional webinar, but instead take this opportunity to do a deeper dive into the nuances displaced people are facing in navigating the challenges of COVID. Our panelists are perfect to paint this picture. Nadia Hardman is a researcher in the Refugee and Migrant Rights Division of Human Rights Watch, monitoring and documenting human rights abuses against asylum seekers, refugees, and migrant populations. Prior to Human Rights Watch, she led the International Rescue Committee's protection program for Syrian refugees in Lebanon and was based in Mosul, Iraq, with the Norwegian Refugee Council working with internationally displaced people. She's a qualified UK lawyer with a master's in human rights from the University College of London. And Dr. Trina Helderman is a board-certified emergency medicine physician with her MPH in forced migration and health. She has a 14-year experience of humanitarian health work responding to sudden onset disasters and has led outbreak responses for cholera, measles, meningitis, and hepatitis E in South Sudan, Ebola during the 2014 outbreak in Sierra Leone, and worked in public health projects in the Dominican Republic, Ecuador, India, Ghana, and Kenya. Currently, Trina serves as health advisor to Medical Teams International. The panelists' full bios are accessible on PMD's Community of Practice, and we'll drop a link in the chat box. We like to have these events as participatory as possible. Please enter any comments or question in the chat box, and we will address them in the final 10 minutes. Any unanswered questions will be taken up in the Community of Practice. Nadia, let's start things off with you. Please tell us a bit about your work with your organization and what it does with displaced populations and how that work has been impacted by the COVID pandemic and how your organization has responded to help them during this pandemic.
Thanks, Kate, and thank you very much for hosting this webinar. I think it's very timely. So I am a researcher at Human Rights Watch, and my background is in human rights and international law. So I should say at the outset, I am not a global health expert. I've learned a lot of new terminology this year, that's for sure. So what I have spent a lot of the last year doing is it's generally what I've been doing in my career anyway, but documenting violations experienced by refugees, migrants, displaced people everywhere. And of course, in the context of COVID-19, that has meant looking into discriminatory practices, restrictions against refugee populations that don't apply to the rest of the population, for example, or the different ways in which people who find themselves in immigration detention might experience COVID-19. And in the context of access to the vaccine, we are trying and advocating at a global level on vaccine equity to make sure that people who are marginalized often in displaced context are not left behind in what is this, the most essential race to get inoculated. I guess the most important thing to highlight in the context of what we do is that we fact find. We're evidence gatherers. We don't provide services at Human Rights Watch. We're a watchdog. It's our job, and it's been my job, to bring forward the voices of refugees and migrants into this space to ensure that qualified people like Trina and your and PQMD members have the kind of information that is needed to drive programming. That's what we're trying to do. So that is essentially what I have spent a lot of the last year doing. And I can go into some of the findings in different contexts. I'm usually based in Lebanon, which has the highest per capita population of refugees in the world. I'm in London now, but we'll be back in Beirut at the end of June. And it's been an interesting ride seeing how the pandemic has played out, definitely in that context.
Thank you so much. And Trina, the same question for you. Please tell us a bit about the work Medical Teams International does with displaced populations, how that work has been impacted by COVID, and how your organization has responded to the pandemic.
Thanks, Kate, and thanks for welcoming us and allowing me to sit on this panel. I think it's going to be a really interesting discussion. Medical Teams International is an international non-governmental organization, and we work to come alongside refugees, displaced populations, and the communities hosting them to break whatever barriers may be existing to enable access to health services. And so that may be at the primary healthcare level, secondary care, such as in hospitals, but then also at the community level. And in each country we're working in, so we're in 8 countries globally, covering all the various areas, so Latin America, Africa, Middle East, and Asia. In each country, we're trying to help build the local capacity of the Ministry of Health, but then also filling gaps to services. So each country where we're working, it looks a little bit different. Some areas we're directly providing healthcare. In other areas, we're supporting the Ministry of Health so that they're able to provide for both the host community, but then those who are displaced within that location. When COVID happened, we had all of our baseline foundational programs running, and then we had to make in our organization, the key term is pivot. So a major pivot in trying to see how do we keep doing the activities we're doing, which many we would label as essential health services. How do we keep doing those safely for both the healthcare workers, for the communities that we're working in? And a lot of that initial stuff was work around risk communication, engaging the communities, helping them to know about COVID, what to do, how to get treatment, but then also working with health facilities to train healthcare workers on signs and symptoms and screening and infection prevention and control, how to use the personal protective equipment, all of that to basically enable those services to continue. But then in some locations, so in Uganda and in Bangladesh, that has also meant that we've helped to establish COVID treatment centers. And so we have those running currently with actually surges in cases in both Uganda and Bangladesh right now. So those isolation and treatment centers are quite busy. In the last few months, we've had a bit more of a shift in looking at the rollout of vaccination, which we'll be talking about today. And so our role in that has been different in each of the countries. And some, it's just informing the community of who's able to get vaccinated, how to get vaccinated, where to go, the safety of vaccines. There's been a lot of issues around hesitancy and misinformation. So working within that space, but then also in some locations, we've been part of vaccination teams. So helping sort the logistics, the actual distribution, the working vaccination sites, and then a lot of advocacy. So in areas where the targeted groups we're working with, refugees or migrants, are not being included, are not having the same kind of access, trying to advocate in whatever forums we have open to us to be able to encourage that they can get the same type of access as others. So that's what we've been doing in the past year, I guess.
Great, thank you so much. And Nadia, from the research and monitoring that you've done around vaccine equity issues for refugees and internally displaced people, can you talk a bit about why these vulnerable populations are being left behind in the race to vaccinate the globe?
Sure. I'm going to start with a couple of statistics because I always find them helpful just to frame, the context and the substance. So 85% of vaccines have been administered to date in high income and upper middle income countries, while 85% of the 26 million refugees worldwide find themselves in low and middle income countries. That just, gives you an idea how many people, how many refugees do not have access to the vaccine right now. As of the 1st of June, I still think this is the case, no one has been vaccinated in the largest refugee camp in the world, in Cox's Bazar. Where I live in Lebanon, where you have 1.5 million Syrian refugees. Today, I just checked the latest dashboard, only 0.93% of all vaccines administered went to Syrians. So the numbers are quite shocking. To me, I mean, I think the thing that the one of the main issues that the pandemic has highlighted, and particularly around vaccine access, is how people who are marginalized and vulnerable, displaced people have experienced the pandemic in a marginalized and often discriminatory way, whether that's direct or indirectly. You will find populations living in camps, in urban settings, but often under the radar. So the access is one of location, but also of transport, of being able to afford to access a vaccine center, for example, information that is understandable, that is also translatable, and that is disseminated to hard to reach places. I mean, of course, there are areas that are non-government controlled, for example, where displaced people also live in conflict zones. As I said, in camps, you might consider that a space where it would be easy to administer the vaccines, but as we've seen in the largest refugee camp in the world, there are still issues. I want to caveat all of this by saying that I understand that is a general issue with global supply, which I won't get into because I'm not a public health expert. But so I'm going through the other reasons which very much fall on marginalization and discrimination. There is a massive issue that we've seen in relation to documentation. I know Trina will go into this a little bit more as well. A lot of the national vaccine plans that I am aware of may include refugee and displaced populations and undocumented migrants, but in some form of another, the administration requirements, the identification requirements that go with the actual implementation of that national vaccine plans leave behind populations that don't have documentation, that are stateless, or that are fearful of registering, for example, on a centralized database or system. I interviewed over 20 people at the beginning of the vaccine campaign in Lebanon. And in a country, and I'll go into more of this a bit later, but in a country where refugees have been subjected to hostile policies for the last decade, found themselves being asked to sign up to a centralized system that was administered by a government that has basically told them to go home and that they are not welcome. And they told me repeatedly that they were too scared to go to a vaccine center. I mean, first of all, they didn't have the kind of information that they needed. They thought they would have to pay for the vaccine. They didn't understand that they were included in the national plan. But then they ultimately said, yes, but I may be arrested at that vaccine center. So why would I present myself? We are campaigning and will continue to campaign on the fact that there needs to be firewalls, immigration firewalls that ensure that people who present themselves at a health center are protected from immigration enforcement activities, because this is repeatedly what people are telling us makes them fearful to engage in what is a public health benefit for them. This is not just an issue in the global South. We've also documented how in Europe, in countries such as Germany, Greece, Italy, Poland, and Spain, even though, again, the national plan includes essentially everyone living on the territory, in practice, you are required to produce some sort of social security number or, again, public health number. And these are the kind of administrative hurdles that mean that people are unwilling or just unable to present themselves and go forward. I could go on. I think I'll stop there.
Great. Thank you so much, Nadia. And Trina, I have a two-part question for you. During an earlier conversation, we talked about the challenges displaced populations face even when vaccinations are available. You noted that the issues of documentation and digital access are critical. Can you elaborate on that? And can you also explain what COVAX's humanitarian buffer is and speak to its potential impact in immunizing neglected populations?
Sure, yeah, I think just going off of what Nadia said, not having paperwork or IDs can be really difficult when you get to the vaccination site and they require you to show that to be able to to get your vaccine card or even to be able to register. And one of the other challenges we've seen is several countries have set up online vaccination registration portals. So you have to go online, enter your information in, and a lot of the refugees or migrants may not have access to internet. They might not have smartphones so that they can do it online. And so that already creates a barrier. They can't even get registered to be able to access the vaccines. And in some locations where you can just show up, they may not have the knowledge about when to show up, where to show up. And so that limits their ability to get the vaccines. I think one of the things you mentioned is COVAX. And so if for those not maybe familiar with it, COVAX was basically a platform to have higher income countries and lower income countries kind of pool their resources to procure vaccines at a better rate. So by having them come as a larger population, kind of like buying insurance, if you will, that you can get a lower rate because there's more vaccines being procured. And so that gave those lower middle income countries the same kind of access perhaps that higher income countries had. And in that, some of the wealthier countries have donated vaccine supplies as well that would come as free vaccines to some of those countries. Within that, they have allocated 5%. So 5% of the funding that's coming into COVAX is going towards what's called the humanitarian buffer. And that humanitarian buffer is expected to be at like a cap of about 100 million doses. So I believe the last number I saw was like 123 million, perhaps people might potentially fit into this humanitarian buffer pool. So there's not enough to cover everyone. And it's really meant to be a last resort. So in order for this humanitarian buffer to be used, they're asking the applicant, so the agency or whoever's applying for that humanitarian buffer, to kind of prove that this targeted group of people will not have access within their country through the normal mechanism. And that may be ever. So in some countries, we're seeing the rollout is extremely slow. And so it's trying to say, well, yeah, they just haven't gotten to that population yet. So there's that you need to kind of prove against. But then in other places, it's trying to prove that, yes, they're not included in the distribution plan at all, or the government has perhaps demonstrated that after multiple efforts and having received vaccines, that yes, this group is still not receiving the vaccination. And so far, COVAX overall has distributed 78 million doses, and those have gone to 120 different countries. So that was as of this morning, looking on their website. And we did hear that there were, I believe it was 500 million extra doses that were going to be donated by the United States that had come through agreement with Pfizer that was also going to go out. So looking at that, I think that that's really helpful. It's really important to know that countries are going to have more access to vaccines, but some of those logistical things still fall into place. Countries then have to be able to receive the vaccines, store the vaccines in cold chain for the amount of time they need, get them distributed out to the decentralized sites, and make sure that those vaccines can be used before they expire. And so there's all of these knock-on effects. And one other thing that just came out recently, again, looking at this humanitarian buffer, is on just June 2nd, so about a week ago, the Interagency Standing Committee COVID-19 group wrote a paper basically noting that the agencies applying for this humanitarian buffer do not want to take on the legal ramifications that are placed on them to ensure that the vaccines get out, are delivered, they're not expiring, they're going out to the right populations, et cetera, because that's a huge liability that they're having to take on. And so there's a lot of other barriers that are coming up. It's not just as simple as, yes, you now have the vaccines, go and give them. And so trying to figure out, how do we get around some of these barriers? How can we ensure this access? Because it's not just, political will, it's, funding, it is, a variety of different things that are impacting and making it difficult for, host communities, but then also these marginalized populations are just further left down the line.
Thank you so much, Trina. I think your comments about the COVAX facility speak to a broader problem that we have regarding diseases that affect marginalized populations. The fact that there's not a market, that wealthy people buy vaccines or buy treatments, whereas poor people, of course, don't have the resources to, and the need to create a market or create advanced market commitments so that vaccine manufacturers will create products, knowing that whether it's donors or wealthy countries will commit to buying those products. And that's what we saw via the priming of the pump the US and the UK and COVAX and some other countries did by assuring these vaccine manufacturers that if they were to produce a vaccine of a certain level of effectiveness, that these countries in this facility would purchase a set number of millions of doses of that vaccine so those manufacturers could recoup their costs. Now, Nadia, you're based in Lebanon, which, as many audience members know, hosts 2 million refugees, the largest number of refugees per capita of any country. The refugees make up more than 20% of Lebanon's population. It's the highest refugee to population ratio in the world. From your vantage point, can you give us a feel of what it's like for a refugee, maybe from Syria, to try to get vaccinated?
Thanks, Kate. I'd preface this answer with a kind of opening statement that despite the fact that refugees make up nearly a third of the population, it is estimated, their access to services is extremely limited. The authorities in Lebanon pursue a strategy of designed marginalization to ensure the temporary presence of refugees in Lebanon, to basically squeeze them so hard that they will make the decision to leave. That has been the policy and the strategy for definitely the last 5 years, and it's gotten a lot worse in the last 2 years. Now, on the vaccine specifically, to Lebanon's credit, and with the very good lobbying of international agencies based there, the national plan extends to all people living on the territory of Lebanon, which includes refugees, includes migrant workers, of which there are also a large number. So on paper, a Syrian refugee has the right to go and get vaccinated according to the criteria that is set out by the government, which is pretty standard in terms of vulnerabilities and comorbidities and age, etc. But as I said, the statistics, the numbers, the reality is, as of today, only 0.93% of all vaccinations in Lebanon have gone to Syrians. And that is, again, because the information campaigns have just been inadequate, have not reached the communities in the way in which they should have been. There is an obligation on the state to provide that information, to provide it in a way that's accessible, and in the context of Lebanon, to ensure that there will not be any consequence for presenting yourself at a vaccination center without the necessary documentation, because 80% of Syrian refugees in Lebanon do not have legal residency. They don't have the right to live there. So they are already in an irregular, Human Rights Watch, we avoid the word illegal. We don't like saying illegal people, but so they're in an irregular situation, and presenting themselves, writing their details, quite extensive amount of details, ID numbers on a centralized system to notify the government that you are here illegally. I mean, they know, but they may not know exactly where, and your ID number is quite a scary affair. And people have consistently and continually told me that they fear arrest, potentially not at that moment, but at a later date. So I will, applaud Lebanon in the last couple of weeks has really made an effort to run vaccine marathons. There were open walk-in centers that opened up in the last few weekends, which I understand UNHRC has also been working with and facilitating, and there have apparently been more migrant workers, especially in refugees, presenting themselves. There's also a huge amount of vaccine hesitancy, as in many populations, but that, there are rumors that spread. I've seen the kind of WhatsApp messages that go around, and, they're quite terrifying in their inaccuracy and the misinformation. But again, there just hasn't been the commitment and the effort to reach these populations, a third of the entire population of Lebanon, to ensure that people are able to get the vaccine. There is also just one other issue I would add with Lebanon. I mean, it's in devastating economic freefall. And there is, and as I've heard in other contexts as well around the world, a feeling that potentially COVID isn't your biggest threat. You know, when you can't afford to get food, when you are literally doing the bare minimum to survive. I spoke with a woman who has 3 handicapped children, children with disabilities the other day, and you know, she sold her kids' wheelchairs to afford rent that month. And the idea of putting vaccines and getting to the vaccination center as, you know, a priority in this woman's priority list was, you know, is not potentially going to work. So in those contexts, you know, you have to make it, you know, accessible in a really realistic and way. And that means often bringing the vaccine to those populations through mobile centers and making that kind of opportunity cost extremely minimal. But it's, yeah, and I mean, I continue to monitor the dashboards and the statistics and just hope that it will get better, because a third of the population we're just simply not going to get to a point of herd immunity without an increase in that figure.
Those are great points about the fact that a COVID vaccine might not be a priority for someone who's worried about where their next meal is going to come from, or who might be worried that, you know, their daughter will get raped getting water that day, or you know, just the idea of sort of in the hierarchy of needs, so trying to satisfy other needs first. So very, very good points. And so Trina, the same question for you. I know that Medical Teams International works in Colombia. Could you help us picture the process for a refugee trying to get a COVID vaccination in Colombia?
Yeah, Colombia has been quite challenging just in terms of the vaccination rollout has been quite slow, and it is encouraging. The government's made a lot of efforts recently to scale that up, and I think they've actually been able to move on to some different targeted groups as they've been able to expand distribution and actually get vaccines rolled out. But in Colombia, the Venezuelan migrants kind of fall into a couple of different categories. There's those that are registered or considered regular migrants, so they're documented as official migrants within the country. And then there's those that have not been registered or are irregular. And estimates around 55% or so, that was from like December last year, said that 55% of those migrants are actually irregular. So if we look at the other 45% who are perhaps registered as official migrants, in order for them to have access to vaccination, they have to have that registration, but then also be registered for health access. So that could be with a type of, it's a type of social insurance scheme or other types of health platforms that enable them to get access to healthcare as a typical citizen, if you will, of Colombia. And so there's the first registration, then there's the second registration for healthcare access. And then once they get to that point, they can then register to get a vaccine, which can be done a couple different ways. One is through an online platform again. So they may or may not have access to, you know, a smartphone or internet access to be able to get on and to do that online registration. And then if that doesn't work, there are a few centers where you can just have walk-in vaccination and they can show up, but those tend to have extremely long lines. And from what we heard anecdotally from a few people who've tried to go to either through the registration process or to go to the facilities, that sometimes they get there and then they're kind of turned away. So perhaps they're turned away because they've used up the vaccines for the day, or perhaps they may be turned away because actually there's still a lot of stigma and there's a lot of xenophobia and you know, this concern that I don't want to be vaccinating someone from this group who I don't think as highly of as, you know, a local citizen. And so there's still a lot of challenges within that and trying to ensure that that access is equitable. But even getting to that point of having to deal with potential stigma, there's multiple barriers in front of them before that. And then again, it's still based on targeted groups. So I think that they're currently to the second age population, which I think is around 50, but I'm not certain on that. So if you're over that age group, then yes, you could go, but then anyone below that, chronic diseases, other types of high-risk groups still have not yet been included. So it is still quite a long way off for some in this population still.
Great, thank you so much. So Nadia, obviously COVID-19 has changed the daily life, rituals, and challenges of everyone on this webinar, but can you talk to the specific new obstacles it created for displaced populations?
Yeah, absolutely. I mean, so many of the displaced populations, the refugees that I talk to, are living in, are food insecure, are living in low and middle income countries anyway, are in an environment where they, have economic challenges. And then COVID-19 happened. We had waves of xenophobia as well, and backlashes. I documented very early on in the pandemic, the very brutal and lethal push of Ethiopian migrants in northern Yemen to Saudi Arabia, where they were shot at both sides. And the reasons given was the coronavirus. People, the Houthi forces wanted them out. And then they ended up languishing in detention centers in Saudi Arabia with no access to COVID-19 healthcare. So what we saw is how marginalized groups, vulnerable groups, found themselves even more, marginalized for different reasons, for not being able then to access livelihoods, or education, where suddenly you saw everyone going online, but that relies on you having access to an internet, a laptop, a mobile phone that works. And you have countries which imposed blackouts, internet bans on displaced populations, for example, in Rakhine State in Myanmar and in Cox's Bazar for some time as well, although now that's been lifted. So policies, people adapted to COVID-19 life, but it was very difficult for a lot of the displaced populations that I was interacting with to adapt. In Myanmar, where you have 300,000 IDPs living in effectively apartheid conditions in internment camps, their restrictions on movement were so severe and faced physical corporal punishments for just moving throughout the area of their camp. And their ability to access livelihoods was just completely cut off. So they relied on fishing or some kind of farming work. Previously, through the pandemic, they just didn't have that. So many refugees rely on humanitarian actors for life-saving services. Whether that be food or protection assistance or and education and formal learning centers. Suddenly that was all cut off. And that was effectively their lifeline. So people's lives just, were dwindled into what could be accessed remotely. But in so many situations, that's very little and relies again on access to working internet and some kind of device. So yeah, it's been quite startling just to, everyone has felt, I felt the challenge of the pandemic, but in the context of people whose reliance on external actors, such as humanitarian agencies that couldn't get to them, it really has been just quite humbling to hear them to tell me their experience of the pandemic.
Thank you so much, Nadia. And Trina, can you please apply a health lens to Nadia's response and elaborate on the additional risks COVID-19 has placed on these populations, specifically within the context of low and middle income countries?
Yeah, I think that there's a couple of key aspects of this that I think are important. One is just general health services. So where we have had just the fear of COVID, people are less seeking of health services. So people are afraid to go into clinics because they may get sick or they may be isolated. I think that was something early on people weren't aware of the requirement for isolation for COVID. So they would suddenly show up to the clinic, they would be screened out and then suddenly locked away, not understanding what happened. We can't communicate with our family. So there was a lot of fear related to that. But then also as healthcare workers became ill, they were isolated, clinics would have to close or they would reduce in staffing. So services weren't being provided at the same rate. And so just the, basic things like your antenatal care or your delivery at a health facility, getting kids vaccinated with just basic EPI vaccines, a lot of that stuff was lacking. And so we've seen, outbreaks of things like measles coming up more frequently, or there's more deaths from malaria than what we had before because children aren't getting treated as early as they should have been. Also increasing rates of malnutrition, as Nadia mentioned, decreased livelihoods and economic purchasing power, less food. So children aren't getting the nutrition that they need, but then maybe they're also not getting screened as early as some of those baseline health activities aren't happening. And so therefore they're worse off by the time we do see them in the clinics than perhaps they would have been in a more normal situation where community health workers are active in the community and moving around. So I think a lot of the normal illnesses that we see in a lot of these low middle income countries, for sure, a lot of communicable diseases are more impactful than what they had been prior to COVID. And I think one other piece is with less opportunity from the standpoint of work, more people at home, we hear more domestic violence, more gender-based violence, kids not going to school, more young pregnancies in girls. And so all of these things will have a broader impact just in terms of future impact of younger girls pregnant. We saw this with Ebola as well in West Africa before. Just the knock-on effects of having young single mothers perhaps who are pregnant, delivering children, and then the effects that has on them a little bit more long-term economically and whatnot. So I think that just baseline health access has been hindered. And a lot of the larger health outcomes that we've been working towards, like with the Sustainable Development Goals, for example, have taken a huge hit just because of the shifting of activities and interventions and prioritization because of COVID.
Fantastic. And I think, a good way to close out this part of the dialogue today is to talk about some successes or some good practices or best practices. What are any best practices or rollout triumphs that you would like to share? And Nadia, I'll start with you.
Thank you. I think probably everyone knows the sort of poster child, at least in the Middle East, for refugee vaccine access, that was Jordan, and that famous first photo of an Iraqi refugee getting a shot of the vaccine went viral in my circles, at least, because it was just so good to see, not just the promise of the vaccine for everyone living in Jordan, again on paper, but actually the practical implementation of it. And I think a third of Jordan's refugee population have received, I don't know if it's 1 or 2 shots, but have had access to at least 1 shot of the vaccine, which is great, which is really, it also demonstrates that it's doable. I mean, Jordan finds itself in a different position, I would say, than Lebanon in terms of its economic stability. But it is great that this is actually happening. You had the health minister from Jordan making a very public address. So you had that information campaign and that kind of propaganda at the outset, calling for refugee access to the vaccine early on, which instilled trust. And I think that's something that, we hope to see, we wanted to see emulated in Lebanon, did not. Again, I would probably say I would applaud Lebanon for the last few weeks' attempts at these vaccine marathons, where you have seen higher levels of refugees and migrant workers sign up, go to these walk-in centers. And if that's the way to do it, then that's the way to do it. At this stage, people just need to get the vaccine. I mean, generally, there are many instances where national plans promise access. I think I read today that out of the 157 countries that UNHRC is monitoring, 150 have said publicly or privately that they will include refugees in their inoculation campaigns. The question is the practical implementation, like how is it going to happen? That's the bit that, you know, we are spending a lot of time monitoring to actually see if it happens in practice. But anyway, that's some happy story.
Thank you. And Trina?
Yeah, I would like to talk about Uganda. So Uganda has the comprehensive refugee response framework that they had established several years ago, and it basically has the goal of kind of accepting refugees as equal to anyone within the host community. And so they have access to land, to jobs, to healthcare, and also the services that are being provided by humanitarian agencies are meant to support both the refugees and the host community and kind of scale up the health services across the country in those more rural and hard to reach areas. So with that, the vaccination rollout plan for Uganda included refugees equally to the host community based on the targeted groups. And we have seen that rollout happen. So in some of the locations we're working in, that has gone very well. So in Nakia Valley, which is more in the southwest part of the country, they're currently at 81% coverage of all targeted groups based on that rollout plan. And so that includes both host community and refugees, which is really encouraging that since March 10th. So, you know, in a few months, they've been able to get those groups covered. But in other locations, there's still a lot of challenges where it's lagged behind. There has been a lot of issues with vaccine hesitancy, which had kind of forced the government to withdraw some of the vaccines in the more decentralized locations, as they've been afraid that those vaccines might expire because they won't be used. And so there's still a lot of challenge with ensuring we can get the vaccines to the places where the the refugees are, the host communities, and those same, somewhat marginalized themselves as they're in more remote areas within the country, and trying to ensure that we can get the desire for the vaccines to be equal to the amount of vaccines available, so that we can get that out and not face some of these challenges of them being withdrawn again, in order to prevent expiration or wasting, which is another challenge on top of you do all the things right, and then actually you still come to a place of how do we ensure that vaccines are not expiring because we have them sent out to places where people just don't want to take them.
Fantastic. Well, thank you so much. And we now have time for a question and answer. So I encourage people to put any questions or comments in the chat box. One that we have here is from Gretchen Warwick. And she asks, vaccines are a central government public health response. What can multilateral organizations like the WHO really do to affect true change? So if either of you would like to address that.
Yeah, I think that this is a big challenge. WHO can advocate and try to use science and data and demonstrate the why and the rationale, and help to encourage governments to understand all of the knock-on effects of if you are only vaccinating this part of your population, you still leave people at risk. If this part is not, how the pandemic could propagate if certain groups just aren't vaccinated, and we continue to have this reservoir of different transmission. But I think it's also good to recognize the reality that WHO can't force governments to do anything. We have seen in different countries, Tanzania for a long time wasn't necessarily even accepting that COVID existed. And at the moment, there's not really a plan for them to take vaccines into the country. And so as there has been this kind of global shift of really recognizing governments are autonomous, they can make decisions about what happens in their country. how things are rolled out. It is their decision, and it's trying to use a lot of leveraging and negotiation and goodwill and try to encourage the best use of products that is possible. And I think that there's only so far, it's only so far that WHO has capacity to really drive different things. So encouraging policy, demonstrating how things have worked in other countries, showing how the country benefits when they see what's happening elsewhere. I think those are all helpful, but ultimately each government has to approve the vaccine. Each government has to decide how they're going to roll it out. And each government ultimately as well has to come up with the funds and the resources to be able to do that. And sometimes that's using humanitarian partners, and other times they choose to do that on their own, and they have that choice.
Nadia, did you want to comment on that question?
Yeah, it's a really difficult one in it, because of exactly what Trina said. I mean, governments have this responsibility. It's a duty of the state. And multilateral organizations obviously have leverage, absolutely. But to what extent, where does that leverage stop and start at is an interesting question. At the beginning of the vaccine campaign and rollout in Lebanon, MPs jumped the queue and were vaccinated in secret. WHO had publicly stated that if Lebanon breached the national plan, they would reconsider funding, because they had provided, WHO has provided a loan to Lebanon to assist in the purchase of coronavirus vaccines. I don't think, that did not happen, because at the same time, and this was a big debate on social media, where people were weighing in saying, MPs get vaccinated and we, get punished for it. And it was a very, we were trying to think through what would be, our recommendation. It's not really for Human Rights Watch to weigh into that. But as people in Lebanon, I had an opinion, but it was a difficult question. And again, the only way I can think it through is through leverage. I'm not sure that cutting the lifeline, cutting the loan would have been the answer, because again, it's the population that will then be the ones, taking the hit for what essentially are corrupt politicians.
That the most vulnerable people would be hurt by that.
Yes. Yeah.
So I certainly see WHO, providing data, that data that look, if we don't help, through vaccination and other means, stop these outbreaks in India or in Brazil, we'll end up with more variants, and we'll have, variants that, are resistant to the vaccine. So COVID will be around forever. So it's in everyone's best interest. So you see the information sharing and the advocacy around that. I also see I wish I had a better term, but I'll just use the term like shaming, public shaming, because I think actually that's what the term vaccine nationalism is. Nationalism is an ugly word. There's no doubt about that. And so I think by, the term vaccine nationalism, I think it does cause a certain amount of embarrassment, in the high income countries. And so it's just interesting to see how all that plays out. But we have another question here. What regions or hotspots are you most concerned about? Which IDP refugee populations do you think are most at risk? I mentioned India. I think, it's a perfect storm, a very large population, very high population densities. You also do have quite a number of displaced people, including, sort of a new type of displaced people displaced by COVID. A lot of, rural Indians who were living, in the big cities were told to go home, and we saw people dying there and kind of being displaced. But please, what other areas are you concerned about?
Well, I think there's the areas of general concern just where we're seeing COVID surging now. So places like India, Bangladesh, Latin America, I think Argentina, Chile, Colombia, Brazil, like surges coming back. We're seeing a new surge in Africa that we didn't see before. But I think if we look at what we know about COVID, so it's people who are older, people who have chronic diseases, so hypertension, diabetes, and then looking at places where we do have higher COVID prevalence. I mean, some of the places I would be most concerned about the refugees would be someplace like the Syrians in Lebanon. Syrians there's a lot of older population, there's a lot with chronic illnesses. And so from a risk perspective, I think that they would fit that category. Yeah, I think, there's a lot of new information. Recently, we saw the report from, I think it was Malaria Consortium, that in places where there's high prevalence of malaria, they seem to do better with COVID. And that would match what we've seen, for example, within our Uganda programs, that we haven't seen a lot of really high levels of deaths and hospitalizations. That we're seeing a lot of hospitalizations at the moment, but with a new surge. But I think it's really complex. And so I do think it's easy to say everyone is at risk, but I also think who's the most at-risk population, it's kind of changing a little bit as the dynamics and the epidemiology of the outbreak. And so trying to figure out where are those really high-risk groups and where is it most prevalent or more likely to be spreading around. And that's really where, if you could target it and you had that ability to really jump in and do that, that's where I would focus in. But that's pretty hard to do.
Nadia, did you want to comment on that at all?
I mean, I go, with the public health expert on that. I mean, I agree. And I think, the variant in India, there's been an increase in cases definitely in the Rohingya camps in Cox's Bazar. I would be concerned about the new waves of displacement in Myanmar. Since the coup, thousands, hundreds of thousands of people are displaced, and the vaccine campaign, from what I understand, is at a complete standstill. And you have a civil disobedience movement where hospitals are essentially on strike. I mean, definitely in those hard to reach areas, non-government controlled areas in Syria, and government controlled areas in Syria, and then in an area again such as Lebanon, where ostensibly it's open to all, but the numbers are still just so low. So if there's another wave, then, I mean, people are, it's opened up in Lebanon, it's sort of business, getting back to business as usual. But as we've seen with the variants, that we cannot take anything for granted. People need to be vaccinated, full stop.
Great, thank you so much. And thanks to both of you. I've really appreciated this conversation. It's time for us to wrap up now and hand things back over to Elizabeth Ashburn.
Hi there, sorry. Hi, thank you everyone for joining us today. And thank you to all of our panelists for your time, insight, and for all the work you do. Such an incredibly fascinating conversation. Kate, thank you for your vision and commitment to bringing this webinar to life, and in doing so, highlighting how we forge ahead together to ensure that no one is left behind in the global battle against COVID-19. We are all in this together, and PQMD will continue to bring you webinars and host intriguing online discussions through the community of practice. Again, I think it was an incredibly stimulating conversation, so much to think about, so much to talk about going forward. So please do check in on the community of practice. And again, thank you for taking the time today, and enjoy. Thank you so much.
Thank you.
Thank you so much.